from the beginning? Okay. So searching for the outcome in the medical ICU for obese patients, again, there was a discrepancy between medical and surgical literature. Here is a prospective study that was done on 550 patients with a BMI above 30. It showed better outcome for patients with BMI above 30 compared to non-obese patients in the medical ICU. Here is a meta-analysis published this year, about the increased BMI in patients with sepsis and severe and septic shock patients in the medical ICU. Mortality in these patients, again, was surprisingly better in the ICU, and there were some theories behind that. Did the patients with a higher BMI have more activation of the renin-angiotensin system, causing them to be more hemodynamically stable? There are other theories. And as you see here, the favored outcome for BMI above the normal was better in general in that meta-analysis. When I searched for literature talking about morbidly obese patients, I found these two papers talking about BMI above 40 as a risk factor for higher mortality. In this paper by El Solh et al. And in this one by Makito et al. Last one. Showed higher mortality for morbidly obese patients, higher length of stay in a hospital, and higher admission rate to nursing homes post-hospital stay. I even found this nice paper in the literature, not even looking into BMI as an indicator for obesity, but looked into the sagittal abdominal diameter, defining abdominal obesity patients from no abdominal obesity patients, and found worse outcome in these patients in the medical ICU compared to the non-obese. And this is where the literature is. So morbidly obese patients do worse than others, but abdominal obese patients do worse than others. So maybe it's not the BMI that we should follow strictly. And there is another theory in some review papers. If you are comparing a BMI above 25 to cachectic patients with a BMI below 18, yes, you wouldn't be surprised finding worse outcome in the underweight or regular weight patients. I'll go through the clinical outcomes of clinical challenges in obese patients, and I'll start with their airway. Airway management at the time of intubation is what I'm going to concentrate on. There are two definitions in the anesthesia literature. One is the difficult to mask ventilate, DMV, and difficult to tracheally intubate. There are factors to affect each of them. I'll run through them fast and then go through the physiology in obese patients. Difficulty in mask ventilation, the factors are the presence of a beard, loss of dentition, BMI above 26, older age, and a Mallampati score of 3 to 4, of course. While the difficult to tracheal intubate these patients includes the Mallampati score of 3 to 4, with the thyromental distance being below 6 centimeters, which is around 3 to 4 fingers. You see the anesthesia doctors always examining that perioperatively on the patients. And the anesthesia literature is trying to add the neck circumference and the BMI above 30 as a risk factor for tracheal intubation. So what happens in obese patients when we are going to anesthetize them, paralyze them, and get them into mechanical ventilation? I'll go through the respiratory physiology of obese patients, but it's interesting to know that they have enough lung inflation when breathing before you put them into sedation, and that lung inflation not only keeps their lower airways and alveoli from collapsing, although they cannot keep all their alveoli from collapsing, and I'll go through that, but that lung inflation also helps keep the upper airways open, and especially the venopharyngeal area. it stays open, and there's a decrease in the closing pressure of that area when their lungs are enough inflated. So you can imagine what happens if you mask ventilate these patients prior to intubation with not with the adequate tidal volume. That's not only going to cause them atelectasis in the lower airways, but it's also going to affect their upper airways. So pre-oxygenation, of course, is what we use, is what we have to do prior to intubation. If patients are on non-invasive mechanical ventilation with some PEEP in their CPAP or BiPAP, the recommendation is to use that in the pre-oxygenation period. And don't forget these three nice, simple tools, because they are a lifesaver in an obese patient or in any difficult intubation patient: oral airway, nasal trumpet, and in the worst case scenario, an LMA. Positioning, we lay everybody flat when we want to intubate them. However, in obese patients, there is something unique. The diaphragm shifts upward when they lay in a supine position. It shifts more when you induce anesthesia, and it gets even worse with paralysis. Was that measured by any studies? The answer is yes. You are supposed to ask me, Ashwin, that question. Yes, thank you, Surah. So yes, it was measured, and I have a study by anesthesia, Demian et al. In 1988, showing that with the induction of anesthesia and paralysis, perioperatively, there was a reduction in the FRC from about 50%, from 2.2 to 1 liter, only with the induction of anesthesia paralysis perioperatively, and you can imagine how much of atelectasis that might cause to the patient. And that's one of the reasons why they would have terrible time oxygenating at the time of intubation. So what is the recommendation? Is to keep them in a reverse Trendelenburg position to make gravity help us with reducing the amount of atelectasis. If you cannot do that, 25 to 30 degrees head up is recommended. Method of intubation in the anesthesia literature is still direct intubation with a Miller or Macintosh plate. They have indications to use fiber optic devices, and it's mainly for a BMI above 60 or a Mallampati score of 3 to 4. I found a nice paper in literature. Oh, sorry. Actually, I have to come back, but that's fine. There was a nice paper in literature just recently published talking about near zero rate of failure using fiber optic devices for intubation in anesthesia, and they use the glidoscope in that study. We do have a protocol at Henry Ford, as everybody knows, the difficult airway, and I think we already went through that in one of the M&M cases recently.
When we're talking about the fiber optic, are those awake?
So the recommendation for anesthesia is 25 to 30% upright, awake intubation with fiber optic device, if possible. Yes. That's the optimal intubation for obese patients. Paralysis, medication and dosing. In anesthesia literature, succinylcholine is the preferred paralytic agent at the induction of intubation. The dose is 1 milligram per kilo of total body weight. In the medical ICU, as we're not allowed to use paralytics, I searched for the right dose for etomidate, and it's 0.2 to 0.4 milligram per kilo of total body weight. If you apply that to our patient, that means he would have received 88 milligrams of etomidate. Would you do that? Actually, there is this recent paper showing that 60% of the obese patients in the ER did not receive the 1 milligram per kilo of succinyl, and almost 30% of them didn't receive the right dosing of etomidate. And on the other side, there was overdosing of these medications in non-obese patients. But that's the recommendation. When it reaches a surgical airway, we have a protocol in the hospital. When you reach the need for tracheostomy, like what happened with our patient, I want to tell you the story of me calling the ENT resident 3 days into admission, and I say, we need a tracheostomy for this patient. So he looks at the chart on the phone and he says, but you haven't tried to extubate the guy yet. Of course, this is the guy who came with a ET tube size 7. His balloon was malfunctioning on the arrival to our ICU. There was gas full in his mouth to keep his tidal volumes adequate, so we had to rush into a tracheostomy the next day. So I told the guy, just, can you please come to the bedside and evaluate? Going into mechanical ventilation, the three goals that we have to reach almost in everybody, but specifically in obese patients, is to prevent atelectasis, which will give us better oxygenation, maintain an adequate gas exchange, and avoid ventilator-associated lung injury. All three of them, the volutrauma, atelectotrauma, and the biotrauma, that I'll go through them. We'll have to go a little bit to physiology, and as we all know, the ARV reduced is the main cause for obese patients to have reduction in their FRC. Obese patients with a BMI above 30 have 30% reduction in both their FRC and vital capacity. The unique thing about obese patients is their pleural pressure. So the transpulmonary pressure is the measurement of airway opening pressure minus the pleural pressure. In normal physiology, without mechanical ventilation, it's measured to be around -5 millimeters Hg. There are 3 reasons for, or maybe 4 reasons for obese patients to have high pleural pressure. One of them is the atelectasis, the increased abdominal pressure, the underlying lung parenchymal disease that they might have during the time of being in the ICU, and of course the stiffness of the chest wall, the low compliance they have. That raises their pleural pressure and makes it less negative, to the point where at some point and in some maneuvers, without mechanical ventilation, just by breathing on their own, they might have an airway opening pressure that is less than their pleural pressure. When that happens, there are theories of why don't their lungs just completely collapse. And again, these maneuvers are either using the accessory muscles to breathe, and their pleural pressure will be higher than the opening pressure of the airways. And the other reasons might be just airway limitation or bronchospasm that also can cause them this physiologic phenomenon. How do they compete this, or how do they defeat this, is by generating some PEEP. So morbidly obese patients, if they are laying flat without being ventilated at home, they will have their own PEEP. Their PEEP is not 0. And I'll go through that when we talk about them on the mechanical ventilation. So as we all know, these equations, I'll go through them in obese patients. Of course, they will have high peak pressures mainly from the limitation in flow, but mainly from the high resistance in their airways. Of course, they will have high plateau pressure, which is mainly from the lower lung compliance, chest wall compliance, but also from the whole respiratory system compliance. They have the tendency for O2 PEEP while they are on the vent, and as I explained before, they have PEEP to start with. Putting them on the mechanical ventilation with all these physiologic changes, they have the tendency for O2 PEEP, and that causes them to have hypercapnia, and we'll go through that in a minute. So why do they get hypercapnic in the ICU? Mainly, if you use this simple equation, we're not going to blame overproduction of CO2, which might play a role if you're feeding them with all the carbohydrates or giving them high dose of propofol, rich in soybean. But this is not the reason why they get hypercapnic. They mainly get hypercapnic because of higher dead space ventilation with all the atelectasis that they have. And if you use lower tidal volumes, or you don't give them enough total ventilation, the VA, the alveolar ventilation becomes low, and their PaCO2 raises. That means we need blood gases frequently on obese patients in the ICU, and you can imagine the challenges of getting them either a radial, femoral, or dorsalis tibius A-line, or an axillary A-line. I have some stories about our own patient in the ICU. You can ask me later about them. This is a trend of the patient's PCO2 in the hospital. He arrived to us with this CO2. We had real troubles, not oxygenating him, but mainly ventilating him. It was obviously chronic because he didn't have acute acidosis, but we have a happy ending on his case at the end. If we cannot get blood gases, the CAPNOGRAM is validated in the literature, even in obese patients, and can be used hooked to the ventilator. The only thing that you have, if you're lucky enough to have, is if you have the blood gases with the CAPNOGRAM, you can see the difference in gap between the CAPNOGRAM and ABG, and then you can trend that gap, and you can even depend on it without a blood gas. Nobody sleeps. I wish Reddy was here. Okay, with all these challenges in physiology, what if the ARDS, what if the obese or morbidly obese patient have ARDS? Dr. Giovanni, I'm not going to go through what we discussed 2 days ago. I'm going to go through it very fast. Obese patients have these physiologic changes naturally. They have high production of adipokines, high cytokines, and dysregulated hormonal production, leptins and others. Does that affect them when they have ARDS? Literature says no. This mainly affects their airway hyperresponsiveness and their tendency to be asthmatic more than others. However, morbidly obese patients have a heterogeneous lung. They have the collapsed alveoli because of all the reasons we talked about. They have the normal alveoli, and they have the areas with cycling opening and closing, and this area is the one that gets the higher shear force. So they have the increased pleural pressure that we talked about, and of course if they have ARDS, within 4 days of being in ARDS, they will have significant increase in their surface tension because the surfactant will be depleted. Conventional ventilation in the past, without looking into the driving pressure, used to cause a shear force on these cycling opening and closing areas that was high enough to definitely exceed a transpulmonary pressure of 25. This is the number we use for safe ventilation. And that, of course, caused the patients volutrauma. If you underventilate them to prevent them from that, these areas are going to collapse more and cause difficulty in oxygenation. So then came the open lung strategy. It started with the what do we call it? Sorry, the recruitment maneuvers. They started with giving the patients very high PEEP for 30 to 40 seconds, trying to open the alveoli and then go back to the same PEEP they have. There are studies showing that this caused volutrauma in 9 to 18% of the patients. So we're not using that, as you see in our ICUs, anymore. And then the high. So how to reach that normal PEEP? How to reach that optimal PEEP then in these patients? Then the literature started studying other parameters, mainly depending on the transpulmonary pressure. A transpulmonary pressure should not be negative, for sure, but also it's safe to keep it below 25, no matter how high the PEEP is going to be. How to measure the transpulmonary pressure? With an esophageal balloon. It's validated even in obese patients if it's in the right spot and you are using it in an experienced center. It gives you a very good estimate about the pleural pressure, and you can use plateau airway opening pressure minus intraesophageal balloon pressure, and you will get your transpulmonary pressure. There are studies in literature that followed the transpulmonary pressure and kept raising the PEEP as long as the transpulmonary pressure is less than 25 to find the optimal way of recruiting the patient's lung. Is that the right thing to do, or is that the only thing that you can look at? No, there is the driving pressure, which is very similar concept. If you use the driving pressure, the difference between the peak and PEEP, and try keeping it as narrow as possible, depending on what we found in the ARMA trial, that's also another option. You can follow the PEEP table, and the high PEEP table recently, depending on the alveoli, LOVES, and the EXPRESS trials, and try keep the PEEP as high as possible with the lowest FiO2 you can. But basically, you're not measuring what I'm going to propose here. You're not measuring the stress index, which is a qualitative measure depending either on the volume pressure curve or on the pressure time curve, and you have to keep your patient in this area. They have to be well ventilated. They shouldn't be over distending or the bird's peak phenomenon, and they shouldn't be definitely under distended. And there are studies just using the stress index to titrate the PEEP. Or there is another strategy in morbidly obese patients with ARDS. It's not unique to morbidly obese patients, but you can use it. Is just using the static compliance that can be measured in any volume-controlled ventilation. Switch the autoflow off. Change your PEEP into 3 measures. The PEEP you have, two above and 2 below, and get your static compliance in each of these changes at the bedside. If raising the PEEP is not raising your compliance and causing higher plateau pressures, you are at the overdistension curve. If your PEEP is causing improvement in compliance without high plateau pressure, then you know that you have room on your patient. Do we do that all the time? The answer is no, and the literature haven't given definite recommendations on doing so. So what do we do nowadays? We're just using the high PEEP table, which seems to work. Of course, ARDS patients with morbid obesity have enough reasons to have air trapping, as we previously mentioned. Now, other strategies in ARDS patients is, of course, proning, and we know what literature is telling us recently about early proning in ARDS patients. I found this meta-analysis that included 2 studies that fit the criteria of testing the effect of proning position in morbidly obese patients with ARDS. The outcome is better for mortality. It's questionable for morbidity in the hospital, but the outcome is good for mortality in morbidly obese patients with early proning. Is there a limit on their weight to be proned? I didn't find specific limiting weight. If anything, it's going to be the technical difficulties. Of course, we still can use the other options are paralysis and ECMO. We didn't have to go through that with our patient. He didn't even have ARDS. But obese patients on mechanical ventilation definitely have higher risk for aspiration, mainly because of the increase in intra-abdominal pressure, the low pH, the low stomach pH, and with mechanical ventilation and increased abdominal pressure, they are definitely at higher chance of reflux. Of course, if they have underlying sleep apnea, that gives one more reason for CO2 retention, and ventilation is going to be a challenge. How about extubation? When to extubate a patient morbidly obese in the ICU in general, not specifically for ARDS. Obese patients, especially if they have OSA, are in the category of high tendency for failure of extubation. I tried to search the literature for what to do. Is it extubation to nasal cannula? Is it extubation to non-invasive positive pressure ventilation, especially if they have a CPAP or BiPAP therapy prior to the acute event that happened? I just found recently this consensus by ATS and ACCP physicians. One of them was Dr. Ouellette, and they asked this specific question. In high-risk patients, where morbidly obese patients, especially if they have OSA, definitely fit in, if they are on more than 24 hours of mechanical ventilation, does extubation to what they call preventive non-invasive mechanical ventilation compared to extubation to oxygen therapy have better outcome in them? And the consensus is that it does have better outcome in liberating them from ventilation, which was defined by more than 48 hours without mechanical ventilation, and they have better outcome in duration of intensive care unit and short-term mortality. So I think this is what might be a good strategy to use, especially in OSA patients, but most of the morbidly obese patients might have it. Okay, Reddy woke up. I wish he was here. I'll go through the cardiovascular challenges in our patients, and it's mainly regarding volume status, assessing volume responsiveness in sepsis. And I wanted to ask this question to Giro, who just came in. When calculating the cardiac index in a morbidly obese patient in a right heart cath, and you want to calculate their cardiac index, you need to calculate their body surface area. So which weight would you use? We're talking about a patient who had a BMI of 132. He was 430 kilograms. So what weight should we use when calculating the cardiac index? Any thoughts? Third one makes sense, but in pharmacological challenges, not in... So the answer to that is total body weight. And this was actually validated in the literature. I have the name of a study. Yes, you use the total body weight, and that's going to help you significantly. There is this study by Stilfox et al. In 2006. So they studied 700 patients with a BMI range between 10 and 91. The patients on two extremes of the BMI were a limitation for their study. They didn't have a large number of patients, but he showed nicely that every 1 kilogram per square meter of increase in BMI was correlating with 0.08 liters per minute of increase in cardiac output and 1.35 mil increase in their stroke volume. For that, they recommended using the total body weight when calculating the cardiac index when doing a SWAN or pulmonary artery cath.
Oh, is it about the normal BMI or from 0 per 1 kilogram?
So they used BMI of 10 to BMI of 91, and they trended the patient's results, and they calculated their cardiac index.
So, using that, what would you have calculated your patient's cardiac output to be? Just if it was normal. So if he has a normal cardiac index, and he's at 2.5 or so, and he's got a body surface area of whatever it would be, what would his cardiac output?
His cardiac output will be high because they have
30?
They will have a high cardiac output state. Depending on this study, their cardiac index is going to be within the normal range, and depending on that, even they said when using volume responsiveness measures like stroke volume variance. Go ahead, doctor. Yeah, so when using stroke volume variance or EDMs, they also, as long as it's a trend, and we know the physiology of obese patients, this is valid to be used as well. So in both SWAN and in arterial line measurements of stroke volume variance.
Yeah, but EDM there, after above 30 is when the EDM becomes not really reliable. Like you say, it's the trends more so. Because that study, EDMs, they took about 2,500 patients who underwent cardiac catheterization. They measured aortic diameter, and they measured the correlation with EDM based on that weight and height. And that's how they came up with the algorithm. So above 30, this kind of falls off. But the reverse thick equation is when you take your VO2 measurement, direct calorimetry, divided by your arterial venous oxygen content. That's the most accurate way to measure your cardiac index. And the PA catheters is more of a thermal dilution methodology. Did they ever look at reverse thick the way that?
I didn't search into that. I didn't go deeply through that. I tried to think of whether they used the FIC or the reverse FIC versus thermodilution. I didn't do enough job on that. Yeah.
That would be the best way because you measure directly by calorimetry, and then you just take an arterial venous sample, and that way the thermodilution may perhaps be You don't know what blood flow to the fat globules are, if they're significant or not.
Yeah. But I did find in lots of cardiology literature the correlation of increasing cardiac output, increasing stroke volume in obese patients, not to affect their heart rate, which means that their cardiac index is going to equilibrate it then to the normal cardiac index. So they don't have a higher cardiac, but they do have a higher cardiac output and a higher stroke volume. But yeah, the ADM point might definitely be valid. They were more talking about invasive arterial blood pressure measurement and using the stroke volume variance in addition to the right heart cath. And if we want to go back to the latest recommendations for volume responsiveness and doing a strict leg raising, it definitely didn't work with our patient. But yes, it did. Yeah, this guy did. So back to Mr. JF. Did I say that he's Mr. JF before? Okay. So he came with Unison for the treatment of cellulitis. He had persistent fever for 3 to 4 days. And the medical resident on the team was asking, shouldn't we cover for MRSA? Because we're covering cellulitis with persistent fever. So vancomycin was added to the regimen. And here are the challenges from pharmacologic standpoint. We'll start in there. So what body weight should we use? Deep, you look interested. So 3. So what's the concept behind? 30% of excess weight. Yeah. It's the content of water in their excessive adipose tissue. That's right if you're using beta-lactams, deep. So if you're using beta-lactams, the answer is 30%. For vancomycin, I went through the literature, and I also followed what Mike Peters and his pharmacists in our ICU published on this patient. They published his case report. They reached a dose of 2,000 BID to reach a trough level between 15 and 20. They definitely had difficult times getting the peak versus trough, but this is the dose they were using. In literature, the initial dose for vancomycin is the challenge more than the subsequent doses where you can just depend on the blood levels, but the initial dosing was dependent on the total body weight in literature. Yeah. I went through other antibiotics, and there is this equation published in this study but followed by pharmacy literature afterwards by Wirtz et al., talking about the aminoglycosides, quinolones, and beta-lactams. And there is what we call the dosing weight correction factor, and it depended on literature to find that aminoglycosides dosing weight correction factor is 0.45 compared to 0.4 for quinolones, but for the beta-lactams it's just the water content of the body, 0.3 times the difference between actual body weight and ideal plus the ideal body weight. This equation of 0.3 times the difference plus ideal body weight is also used when obese patients receive chemotherapy. This is the same concept of the water content in the body.
There's got to, just mathematically, there's got to be a point where you don't have to probably just use that number times the actual, right? I mean, if your actual is 300 kilos higher than the ideal, it's sort of multiplying it by the actual.
Yeah, especially in this guy. Yeah, his the difference was maybe 250 in him. Yeah. Another pharmacologic challenge is sedation in obese patients, and the most frequently used sedatives in the ICU in obese and non-obese patients in literature are propofol, midazolam, and fentanyl. While propofol has the highest or the largest distribution and the fastest acting as a sedative, it doesn't have accumulation in the adipose tissue like midazolam does, but with prolonged use, you will have the side effects of slow to recover, the high triglycerides, and the propofol infusion syndrome. Midazolam is the fastest acting benzodiazepine used. It has the tendency to accumulate in the adipose tissue, so and that's one of the drawbacks about using it in morbidly obese patients. And fentanyl is the most commonly used opiate. I don't have much to say about their doses because we follow the PAT protocol in here, and I found other protocols to be used in other hospitals, and the dosing is based mainly on the effect on the patient. There's something related to fentanyl, which is called the stiff chest syndrome. Very uncommon to happen, but on top of the morbidly obese patients' chest wall low compliance, if they get the stiff chest syndrome from fentanyl, where the treatment is just to stop the medication and give naloxone, you can imagine what might that cause for their peak pressures and lung physiology. The patient continued to have unresolved fever, and that same medical resident said, okay, this guy collapsed in the outside hospital. We don't know what happened. What if he had a PE? We did a Doppler of the lower extremities, and the results, as you can imagine, were definitely unhelpful. He cannot fit into a CT scan, but that medical resident put us into trouble. So what to do? Kareem, what do you recommend?
Never transfer to medical resident.
So actually, we started the patient on anticoagulation. And I searched the literature for the right dosing. As we all know, that low molecular weight heparins have limitations when it comes to weight. I found in the pharmacy literature that enoxaparin can still be used up till a BMI of 48, dalteparin up to a BMI of 58, but acutely anticoagulating patients in the ICU, there are studies to show a lower initial dose of unfractionated heparin in morbidly obese patients compared to non-morbidly obese when anticoagulate them for DVT-PE. The dosing for morbid obese patients is 12 units per kilo compared to 16. And these studies, one of the studies showed the same time to reach a therapeutic PTT on these patients using that lower initial dose. And the 12 units per kilo, it's of total body weight in morbid obese patients. Nutrition, we all know that we cannot underfeed these patients. We cannot say they have enough on their body. Underfeeding in ICU is compatible with higher mortality. We know in obese patients that we should not give them lots of carbohydrates, which is going to increase their CO2 production. We have to give diet rich in proteins to minimize the breakdown of fat in these patients. But the challenges in this patient were not any of that. The challenge in Mr. JF was finding his feeding tube. Believe it or not, we had to ask GI to come do an endoscopy to find his feeding tube, because in this hospital they do not accept a physician coming with a stethoscope onto the stomach and blow air to say that it's in the right place. So we took one x-ray, another one, couldn't find it. So we had GI. And then when he did a TEE, when that medical resident raised the possibility of a PE, we lost the nasogastric tube. So this was another.
You should have transferred the resident when you had a chance.
And that's the patient's x-ray at the day of discharge. Nursing challenges in the ICU. I really would like to thank all the nurses who took care of this gentleman. I just want to tell you some scenarios. Changing posture in him or weighing him on daily basis, there were literally 10 nurses at the bedside helping this gentleman. Of course, morbidly obese patients are at a higher chance of getting pressure sores, mainly because of the under perfusion of the adipose tissue. that is close to the skin, and that gives them tendency for pressure sores. And you can imagine all the other challenges that we face. So in summary, the outcome of morbidly obese patients in the ICU is worse than the rest of the population, maybe not the patients with a BMI above 25. Airway management, I hope you got to get the sum up of getting the airway management in morbidly obese patients at the time of intubation. The recommendation is for upright reverse Trendelenburg at 45. If possible, awake intubation with mild sedation. Use their non-invasive ventilation for pre-oxygenation if possible, and avoid laying them supine. Challenges with mechanical ventilation are still ongoing, especially for the matter of finding the right PEEP in patients, especially if they have ARDS. The tendency for CO2 retention and air trapping is an ongoing challenge in the ICU. Our patient wasn't an exception for that. Hemodynamic monitoring is, I hope you got the message from that. And of course, the pharmacologic challenges are enormous. Where is this gentleman right now? I actually kept following up on him almost every 1 to 2 months, opening the chart mainly. And I just found recently that he went into a plastic surgery clinic where he lost 300 pounds. And he's now at 670 pounds, and he's preparing, if he reaches below 350, to undergo bariatric surgery. He is trached still because of the challenges we had in the ICU, but overall he's doing better. Question?
For nutrition, what formula you use?
So I didn't go through that. I didn't expect time to allow me to do that, but you have to use high protein, low carbohydrate nutrition.
What about the body weight? Which one do you use? Use total, use ideal, or the 0.3?
The literature tested both, and if you use the ideal body weight, there is a very high chance of underfeeding these patients. But if you use total body weight and the total calorie for that, you're definitely exceeding their goals. Yeah. But high protein, low carbohydrate, and enough fat. That's the recommendation. Dr. Rivers.
Excellent lecture, by the way.
Thanks.
I'm a big believer in the metabolic cart because you can get their RQs, you can also get their basically energy expenditures, which are really surprisingly low in a lot of these patients. They may weigh 800, but their actual caloric needs are probably 800 calories a day. And the other thing is, when you mention sepsis, people do better when they're obese.
That's true.
Wow.
One theory is that they have more activation of the renin-angiotensin system, and that they are more hemodynamically